Hey crew, welcome to the MMOA podcast. My name is Shelby Blankenship. I am one of your TAs in live as well as level 2. And today we're going to be talking about lateral and anterior knee pain and a case study that I had recently, and just kind of going through some objective measures that we really kind of honed in on, some treatment ideas and how to progress those, and then just kind of little nuances that popped up with medical complexities for this patient throughout the plan of care, just to kind of give you some more ideas of things to look out for, especially when it comes to medical red flags. Going into this patient, she was in her 70s. She has a little bit of a medical complexity where she has cystic fibrosis, where she didn't get diagnosed till much later in her life, which I thought was super interesting. So overall, fatigue levels and nutrition were something that's really challenging for her. And what was really interesting is that her fatigue levels wasn't necessarily related to like lung capacity. It was more just overall capacity to take in nutrition. She had a chronic issue with nausea and getting her stomach very upset with certain nutrition, really struggled with having to do really specific items when it came to nutritional intake, and that kind of was a limiter for her as far as how much capacity she had. But all that to say, she came in because she was having some bilateral knee pain, but mostly in her left. That was primarily with stairs, getting in and out of bed, and getting in and out of the car. Now, the lateral aspect was kind of more on that IT band specific, where it was more distal around the knee joint, and then the anterior was right below the patella. So we were kind of having a little bit of both. And then she would sometimes complain a little bit about some IT band up in the hip area as well, but it was a little bit more inconsistent. She also had some right knee pain, but it was more anterior and wasn't as pronounced and wasn't like her main objective that we wanted to work on. But basically what I instructed her with is that pretty much everything we're doing for the left, it wouldn't benefit on the right. Now, what her baseline was is she was exercising. She was doing YouTube exercise classes about 45 minutes a day, which was great. Unfortunately, a lot of them were seated, and she is able to do more standing activity. So that's something we kind of worked on later, trying to progress that and kind of push that a little bit more. And then as far as objective measures go, she had great knee range of motion. Her knee flexion, her knee extension was awesome, super impressive, but she was really struggling with a positive Faber test, especially on the left. And then we noticed a lot of weakness in hip flexion, adduction, and abduction. I feel like a lot of people kind of forget about adduction when it comes to older adults, and that is one that we're definitely going to touch on when it comes to exercises to really dive into. Her 30-second sit to stands was a 13 rep, but around 11, she was starting to get that pain, that familiar pain. And as far as that goes, she had a lot of knee valgus, especially on that left side. It was just a very natural position for her. When she was walking, she tended to drag her feet. There wasn't a lot of confidence in her gait, but a lot of just kind of like lackadaisical, just kind of moving around. Now, when it came to treatment, our first objective was to really get after the lateral hip and just posterior chain in general. We really kind of emphasized like side steps were huge. We did the combination where we did above the knee, below the knee, and at the ankles to really get those glutes fired up. One of my favorite ways to do this is to do 2 rounds of doing maybe like 10 to 15 side steps above the knee both ways, and then do below the knee, and then do at the ankles. If your butt is not fired up after that, I don't know what to tell you. You have buns of steel. And then we kind of really started, once we kind of got that as more the HEP, then we started focusing on more like hip flexors and adductors. I feel like with adductors, this is one that, especially when people come in with knee pain and or they come in with like hamstring stuff, this is one I really try to get after. Usually they really lack range of motion in their adductors, especially if knee valgus is very pronounced. And so we worked on some like knee rocks where you're in like knee bent and then one leg is straight out and kind of rocking back and forth to just kind of get a little bit of more adduction range of motion. We worked on some like Cossack squats to kind of load in that more adduction of adductive stress position, if that's the correct term. And then we ended up going into like Copenhagen planks. If you're not familiar with those, the pelvic course is great, going into all the different capacities for doing that, especially if you ever have folks who have knee pain and they've got some pelvic floor stuff. Highly recommend getting after those. And then sumo deadlifts, especially if somebody has a really hard time getting on the ground or knee weight bearing is really hard for them. Cossack squats and sumo deadlifts are great because you're getting that adductor load without necessarily having to get knee weight bearing. Now, obviously, if we can get them knee weight bearing, that's what we want to shoot for, but maybe in the earlier stages, that's not really a capacity that they have yet. When it came to the hip flexors, we did a lot of like banded hip marches, kind of getting in more to that plank position. Hollow holds were really big as well. And then we eventually started working on doing like marches over a barrier. So I had like some yoga blocks and then eventually like a parallel where she would be seated in an elevated position to start and practice that marching over top, because it was more of like a fatigue issue, and just her capacity to get those hip flexors going was really aggravating for her when she was getting in and out of the car, in and out of bed. And so we kind of worked on some ways to kind of ramp down those symptoms. So she would sit into the car and then swing her legs in versus trying to do it all at once where she was swinging her legs in and ducking to get under. And that was really helpful to kind of calm the symptoms down while we were trying to improve capacity. Now, as far as like functional things that we wanted to work on for her, because she definitely had some just kind of like gross all over weakness. Deadlifts with farmer's carries is always one of my go-tos. Loaded sit to stands, of course. Step ups were huge, especially because you're going to get after like posterior chains, single leg balance, adductors, all that kind of good stuff. And then Turkish get-ups and bed mobility. I think sometimes kind of going back to like missed opportunities, adductors is one and Turkish get-ups is one. We so often like forget about bed mobility and being able to like get in and out of bed, because sometimes that is the most taxing thing for a lot of our folks. And so for her, we really focused on like the bottom half of the Turkish get up. So getting through that sit up, getting to the elbow, starting there, then getting up to the hand, and then eventually getting to that bridge position. And sometimes like one side was easier than another. And so you can always use like a banded support, like you would do a banded sit up, to kind of help allow you to load both sides equally as far as the range of motion, but maybe not the amount of intensity, depending on how hard or how limiting that position can be. The other thing that we really focused on for her when it came to functional capacity is uneven ambulation and dual tasks. She was really struggling, and you could kind of almost see it on her face when we would do things like clock yourself or the blaze pods or walking on a crash pad, like that panic that would kind of set in. And she hadn't had like many falls, but it was almost like she was self-limiting to not doing things like exercises because she was so afraid of falling. And so we added those opportunities in there to kind of practice like addressing her fear in a very safe environment, as well as adding that dual task so that she could practice having multiple things going on at once and still trying to finish the task. She does have a history of dementia in her family, and so that's something that she's very mindful of, and just something to always continue to progress and to work on, so that, you know, whether we can like mitigate those symptoms for her or that she for sure is going to have dementia, we don't know, but we can at least start kind of addressing those issues so that if cognitive decline is something that she has to deal with, we're at least trying to create more reserve and resiliency when it comes to that. The last thing that I wanted to kind of touch on is some medical complexities that kind of popped up for her. So I kind of alluded earlier about how, you know, with her cystic fibrosis diagnosis, she was in and out of the doctor's office all the time just for regular checkup stuff, but she really struggled with nausea, abdominal pain, could be very much of a limiter for her. She really did struggle a little bit with fatigue. And I don't know how much of that is just lung capacity versus she just hadn't done stuff like this probably ever, especially with the YouTube exercise videos. I just don't think she was reaching this type of intensity. So she could do maybe like one round of something. So maybe it was like 3 different exercises, and then she would have to take a seated break or a water break for about a minute and a half, and then she could do it again. But she was one that, especially if her nutrition was really limited because of the nausea, because of the just lack of intake, that could be just a fuel fatigue aspect as well that was hard to address. But the other thing is, one day she came in and we had done deadlifts maybe like 2 days before, never had an issue during, with no complaints. And she came in and she goes, I'm having like really bad low back pain. And I was like, this is kind of odd. I was like, can you tell me a little bit more? Like, did it, when did it start? Can you tell me what it feels like? All those kinds of details. And hers had just like popped up that morning, especially with her history and her lack of ability to do as much hydration as she would like. My immediate thought was UTI. And so I was like, hey, like we'll kind of scale back like a few things, but we'll just kind of see how you're feeling and just kind of your fatigue level and, you know, pain tolerance and everything. But I would really highly recommend going to get a UTI like over-the-counter test. And if it's positive, obviously talk to your PC or go to like an urgent care for them to test so you can kind of get on the medications that you need to get on if it's appropriate. And ultimately that's what it was. She had a UTI. She was in her mid to late 70s, so I'm actually really surprised she didn't have any cognitive things popping up, and it might be just because she was on all these other medicines, but it felt like from my standpoint that she kind of got the runaround when it came to urgent cares and PCPs and those kinds of things. And so she was like really having to advocate for herself. And so being on the other side of it, of being like, hey, this is what I think it might be. I can't diagnose that, of course, but I think it would be worth doing these over-the-counter testing to at least take back to your doctor because you have these concerns. She wasn't necessarily having what I would say like, you know, like the burning or those kinds of symptoms. It was more like the pain and just like abdominal like discomfort, bladder discomfort. So ultimately now she's going to be working with a urologist to kind of work through some of that. But it is always worth noting that when people come in with that acute back pain, and especially if you've been seeing them for a while, having that conversation or having them have some resources to see if like it's something else. It's not always musculoskeletal when we see these folks. And so that's the kind of stuff that I think is really kind of differentiates you as a therapist to make sure that you're really getting after those differential diagnoses and not just assuming that everything is in your wheelhouse, because that's just not something I can treat. I can at least direct you to the right people, but I can't treat a UTI. So that's just something to kind of keep in mind. But just kind of recapping everything. We talked about IT, lateral, anterior band or anterior knee pain, and kind of the progressions we went through as far as objective measures, and then going through the different specific treatment styles that we did, focusing on that lateral hip posterior chain. Adductors, of course, hip flexors are always a good idea, and then functional, really getting after those. And having like a little bit of each of those in each session is always a good idea, depending on what their tolerance is. And then really making sure those medical red flags are cleared, giving them the support and resources if they need it. As far as next courses coming up, we have Older Adult Live will be June 6th and 7th in Candler, North Carolina. And then June 13th, we will be in Georgetown, Kentucky. And then L1 just started. May 20th is our start date. We'll be done with that one July 14th. And then L2 will be starting in September 16th to be exact. Hope y'all have a great rest of your day and keep killing it out there.